Okay, Fundamentals 2. Okay, Chapter 16 in Iggy, Care of Preoperative Patients by Robin Shard. Learning Outcomes. For clinical competence and success on the NCLEX examination, study this chapter with these learning outcomes in mind. Safe and effective care environment. Differentiate among the various types and purposes of surgery. 2. Use appropriate patient identifiers when providing instruction, administering drugs, marking surgical sites, and performing any procedure. 3. Verify that the patient has given informed consent for the surgical procedure and that the pre-surgical checklist is complete and accurate. 4. Identify patient conditions or issues that need to be communicated to other members of the surgical and preoperative teams. Psychosocial integrity. 5. Use effective communication when teaching patients and family members about what to expect during the surgical experience. 6. Act as a patient advocate with regard to patients' rights, informed consent, and advance directives. 7. Identify learning needs for the patient preparing for surgery. Psychosocial integrity. 8. Use knowledge of physiology and behavioral principles to describe an accurate and complete preoperative assessment. 9. Evaluate personal factors that increase the patient's risk for complications during and immediately after surgery. 10. Evaluate laboratory values for changes that may affect the patient's response to drugs, anesthesia, and surgery. 11. Explain the purposes and techniques commonly used for patient preoperative preparation. 12. Correctly apply anti-embolic stockings, sequential compression boots, or other devices to reduce or prevent vascular complications. Recent advances in surgical technique, anesthesia, pharmacology, medical devices, and supportive interventions have provided many benefits to the patient undergoing surgery. Research defining best practices has resulted in improved outcomes in all areas of the perioperative experience. New diagnostic and intervention devices for the use and refinement of new surgical techniques are continually being developed. Examples of such technical advances include the gamma knife, all capital letters, gamma knife for brain tumor resections, robotics, and other types of minimally invasive surgeries, or MISs. Advances in anesthetic agents and techniques improve the ways that a surgical patient is treated and has made anesthesia safer than ever before. Many procedures that used to be performed only in the operating room are now being done in other departments such as interventional radiology, cardiac catheterization, and endoscopy. These advancements affect the role of the perioperative nurse and have an impact on how patient teaching is performed. Cost reduction policies by third-party payers are also a driving force for the management of the surgical patient. Shortened stays in ambulatory surgical services are common, with more patients being admitted as inpatients after a procedure rather than before. Some patients may only be observed after surgery and may not be admitted as an inpatient. In response to the ongoing healthcare delivery changes and the use of multiple settings, nurses have modified their interventions, remaining focused on patient care before or preoperative, during, intraoperative, and after or postoperative surgery. Together, these time periods are known as the perioperative experience, or perioperative experience. Overview. The preoperative period begins when the patient is scheduled for surgery and ends at the time of transfer to the surgical suite. As a nurse, you will function as an educator, an advocate, and a promoter of health. The surgical environment demands the use of knowledge, judgment, and skills based on principles of nursing science. Perioperative nursing places special emphasis on safety, advocacy, and patient education, although ensuring A culture of safety is the responsibility of all healthcare team members. The patient's readiness for surgery is critical to the outcome. Preoperative care focuses on preparing the patient for the surgery and patient safety. This care includes education and any intervention needed before surgery to reduce anxiety and complications and to promote patient cooperation in procedures after surgery. Use adult teaching and learning principles in teaching patients and families before surgery. Validate and clarify information the patient has received from the surgeon or other members of the surgical team. In addition, during the nursing assessment before surgery, it is not uncommon to identify problems that warrant further patient assessment or intervention before the procedure. Communication and collaboration with the surgical team are essential so that correct actions are taken to achieve the desired outcome. Categories and purposes of surgery. Surgical procedures are categorized by the purpose, body location, extent, and degree of urgency. Table 16.1 explains the categories and gives examples of surgical procedures. Table 16.1 Selected categories of surgical procedures. Category. Reasons for surgery. Diagnostic. It's performed to determine the origin and cause of a disorder or the cell type for cancer. Examples might be a breast biopsy, exploratory laparotomy, arthroscopy. There's curative. That would be performed to resolve a health problem by repairing or removing the cause. That would be a cholecystectomy, appendectomy, hysterectomy. There's restorative, which is performed to improve a patient's functional ability. That'd be like a total knee replacement, a finger reimplantation. There's palliative, performed to relieve symptoms of a disease process but does not cure. That'd be like a colostomy or a nerve root resection, tumor debulking, or ileostomy. There's cosmetic. It's performed primarily to alter or enhance personal appearance. And that'd be like liposuction, revision of scars, rhinoplasty, blepharoplasty. I'm not sure what that is. So the reasons for surgery are diagnostic, curative, restorative, palliative, and cosmetic. And then it says urgency of surgery. Elective, that'd be planned for correction of a non-acute problem like cataract removal, hernia repair, hemorrhoidectomy, total joint replacement. Then there's the urgent, and that would be requires prompt intervention, maybe life-threatening if treatment is delayed more than 24 to 48 hours. This would be like an intestinal obstruction, a bladder obstruction, kidney or ureteral stones, bone fracture, eye injury, acute cholecystitis. Then there's emergent, and that would be requires immediate intervention because of life-threatening consequences. What's the difference there? It would be like a gunshot or stab wound, severe bleeding, abdominal aortic aneurysm, compound fracture, or an appendectomy. So there's urgent and emergent. Okay. Degree of risk of surgery. There's a minor degree of risk, and that's procedure without significant risk, often done with local anesthesia, and that would be like an incision and drainage, or it's called an IND, or an implantation of a venous access device, be a VAD, or a muscle biopsy. And then there's a major risk, and that's a procedure of greater risk, usually longer and more extensive than a minor procedure. That'd be mitral valve replacement, or pancreas transplant, lymph node dissection. Extent of surgery, simple. Only the most overtly affected areas involved in the surgery, like a simple to partial mastectomy, or radical. That would be extensive surgery beyond the area obviously involved as directed at finding a root cause. That would be like a radical prostatectomy or a radical hysterectomy. There's a minimal invasive surgery. Surgery performed in a body cavity or body area through one or more endoscopes. can correct problems, remove organs, take tissue for biopsy, reroute blood vessels and drainage systems, is a fast-growing and ever-changing type of surgery. And types here are arthroscopy, tubal ligation, hysterectomy, lung lobectomy, coronary artery bypass, and cholecystectomy. Cholecystectomy. So once again, you've got the different types, or the different reasons, which are diagnostic, curative, restorative, palliative, and cosmetic. They can either be elective or urgent or emergent, and they can be minor, major, and they can be simple, radical, or minimally invasive surgery, which is also called MIS. Okay, table 16.2. Selected factors that increase surgical risk or increase the risk of postoperative complications. First is age, older than 65 years old. Medications, antihypertensive, tricyclic antidepressants, anticoagulants, and nonsteroidal NSAIDs. Okay, and so these are things that can complicate postoperative. Okay, medical history, decreased immunity, diabetes, pulmonary disease, cardiac disease, hemodynamic instability, multi-system disease, coagulation defect or disorder, anemia, dehydration, infection, hypertension, hypotension, any chronic disease. Prior surgical experiences, less than optimal emotional reaction, anesthesia reactions to or complications, and postoperative complications made prior surgeries. Health history of malnutrition or obesity, drug, tobacco, alcohol, or illicit substance use or abuse, altered coping ability. Family history, malignant hyperthermia, cancer, bleeding disorder. So tendency to have fever, cancer, bleeding disorder. Type of surgical procedure planned: neck, oral, or facial procedures have airway complications. Chest or high abdominal procedures can have pulmonary complications. Abdominal surgery also can do paralytic ileus and deep vein thrombosis problems. Okay, good to know. Surgical settings. The term inpatient refers to a patient who is admitted to a hospital. The patient may be admitted the day before, or more often, the day of surgery, often termed same-day admission, or SDA, or the patient may already be an inpatient when surgery is needed. The terms outpatient and ambulatory refer to a patient who goes to the surgical area the day of the surgery and returns home on the same day, i.e. same-day surgery, or SDS. Hospital-based ambulatory surgical centers, freestanding surgical centers, physicians' offices, and ambulatory care centers are common. About 70% to 90% of all surgical procedures in North America are performed in ambulatory centers. One advantage of outpatient surgery is that patients are not separated from the comfort and security of their home and facility. With improvements in surgical techniques and anesthesia, more procedures are performed safely on an outpatient basis. Same-day surgery, however, presents new challenges for the patient who does not have an adequate or available support system. An older spouse may be unable to assist in care before or after surgery. Patients who are responsible for others may be unable to perform their usual tasks within the family. They may try to continue their family role but jeopardize their own health by doing so. As a result, their stress, fears, and anxieties about the surgical experience and about returning home immediately after surgery may increase. In these circumstances, a case manager may be assigned to coordinate post-discharge care for the patient. Patient-centered collaborative care assessment. History. Data collection about the patient before surgery begins in various settings, e.g., the nurse, the surgeon's office, the pre-administration or the pre-admission or admission office, the inpatient unit, or the telephone. Use privacy to increase the patient's comfort with the interview process. Anesthesia and surgery are both physical and emotional stressors. Collect these data: age, use of tobacco, alcohol or illicit substances, including marijuana, current drugs, use of complementary or alternative practices such as herbal therapies, folk remedies, or acupuncture, medical history, prior surgical procedures and how these were tolerated, prior experience with anesthesia, pain control, and management of nausea or vomiting, autologous or directed blood donations, allergies, including sensitivity to latex products, general health, family history, type of surgery planned, knowledge about and understanding of events during the perioperative period, and adequacy of the patient's support system. And here is 16.1, nursing focus on the older adult. Changes of aging as surgical risk factors. A physiologic change, we're going to start off with cardiovascular, decreased cardiac output, and increased blood pressure. And nursing interventions for this would be determine normal activity levels and note when the patient tires. Rationale, knowing limits helps prevent fatigue. Also decrease peripheral circulation. Interventions, monitor vital signs, peripheral pulses, and capillary refill. Having baseline data helps detect deviations. So do vitals and determine what the normal level of activity is. Respiratory system, reduce vital capacity, loss of lung elasticity, decreased oxygenation of blood. Interventions, teach coughing and deep breathing exercises, monitor respirations and breathing effort. Pulmonary exercises help prevent pulmonary complications. Having baseline data helps detect deviations. Okay, renal and urinary system. You'd have watch for decreased blood flow to kidneys, reduced ability to excrete waste products, decline in glomerular filtration rate, and nocturia is common. And interventions would be monitor intake and output, assess overall hydration, monitor electrolyte status, and assist frequently with toileting needs, especially at night. Ongoing assessment helps detect fluid and electrolyte imbalances and decrease renal function. Frequent toileting helps prevent incontinence and falls. Neurologic system. Watch for sensory deficits, slower reaction time, decreased ability to adjust to changes in the surroundings. And interventions would be orient the patient to the surroundings. Allow extra time for teaching the patient and provide for patient safety. An individualized preoperative teaching plan is developed on the basis of the patient's orientation and any neurologic deficits. Safety measures help prevent falls and injury. Okay, muscular skeletal system. You might see increased incidence of deformities related to osteoporosis or arthritis. You want to assess the patient's mobility, teaching turning and positioning, encourage ambulation, and place on falls precaution if indicated. Interventions help prevent complications of immobility. Safety measures help prevent injury. Okay, skin. Dry with less subcutaneous fat makes the skin at greater risk for damage, slower skin healing, and increases risk for infection. So you want to assess the patient's skin before surgery for lesions, bruises, and areas of decreased circulation. Pad bony prominences. You want to pad bony prominences, not pad. Use pressure avoiding or pressure reducing overlays. Avoid applying tape to skin. Teach the patient to change position at least every 2 hours. Having baseline data helps detect changes and evaluate interventions. Padding can protect at-risk areas. Overlays can prevent pressure ulcers formation by redistributing body weight. Tape removal damages thin skin. Changing position frequently helps reduce blood flow to an area and changes external pressure patterns. Okay, now back to the text. When taking a history, screen the patient for problems that increase the risk for complications during and after surgery. Some problems that increase the surgical risk or increase the risk for complications after surgery are listed in Table 16.2. Older patients are at increased risk for complications. The normal aging process decreases immune system functioning and delays wound healing. The frequency of chronic illness increases in older patients. In addition, the reduced muscle mass and body water increase the risk for dehydration. See Chart 16.1 for other changes in older adults that may alter the operative response or risk. Drugs and substance abuse may affect the patient's response to surgery. The use of tobacco increases the risk for pulmonary complications because of changes it causes to the lungs and chest cavity. Excessive alcohol and illicit substance use can alter the patient's responses to anesthesia and pain medication. Withdrawal of alcohol before surgery may lead to delirium tremens, or DTs. Prescription and over-the-counter drugs may also affect how the patient reacts to the operative experience. Adverse effects can occur with the use of some herbs, such as those listed in Table 16.3. Table 16.3, potential effects of herbs. So you got black cohosh, that can give you bradycardia, hypotension, and joint pains. Bloodroot, that would be bradycardia, dysrhythmia, dizziness, impaired vision, intense thirst. Boneset, love these names. Liver toxicity, mental changes, respiratory problems. Colt's foot, fever, liver toxicity. Dandelion, interactions with diuretics, increased concentration of lithium or potassium. Ooh. Ephedra, headache, dizziness, insomnia, tachycardia, hypertension, anxiety, irritability, dry mouth. Feverfew, that would be interference with blood clotting mechanisms. Garlic, hypotension, blood clotting inhibition, potentiation of diabetes drugs. Ginseng, headache, anxiety, insomnia, hypertension, tachycardia, asthma attacks, postmenopausal bleeding. Golden seal, do vasoconstriction. Hawthorn, hypotension. Kava, damage to the eyes, skin, liver, and spinal cord from long-term use. Licorice, or licorice, hyperkalemia, hypernatremia. Lobelia, hearing and vision problems. Motherwort, increased anticoagulation. Nettle, hypokalemia. Senna, potentiation of digoxin. St. John's wort, antidepressant photosensitivity. And valerian wort, mild sedative or tranquilizer effect. Hepatotoxicity. Got all that? Okay, medical history is important to obtain because many chronic illnesses increase surgical risks and need to be considered when planning care. For example, a patient with systemic lupus erythematosus may need additional drugs to offset the stress of the surgery. A diabetic patient may need a more extensive bowel preparation because of decreased intestinal motility. An infection may need to be treated before surgery. Ask the patient specifically about cardiac disease because complications from anesthesia occur more often in patients with cardiac problems. A patient with a history of rheumatic heart disease may be prescribed antibiotics before surgery. Cardiac problems that increase surgical risks include coronary artery disease, angina, myocardial infarction, MI, within 6 months before surgery. So any of those 6 months before surgery can cause risks with anesthesia. Oh, also heart failure, hypertension, and dysrhythmias. Okay, just MI is the one 6 months before surgery. The rest are just history of. These problems impair the patient's ability to withstand hemodynamic changes and alter the response to anesthesia. The risk for an MI during surgery is higher in patients who have heart problems. Pulmonary complications during or after surgery are more likely to occur in older patients. Those with chronic respiratory problems and smokers because of smoking or age-related lung changes. Increased chest rigidity and loss of lung elasticity reduce anesthetic excretion. Smoking increases the blood level of carboxyhemoglobin, or carbon monoxide, on oxygen binding sites of the hemoglobin molecule, which decreases oxygen delivery to the organs. Action of cilia in pulmonary mucous membranes decreases, which leads to retained secretions and predisposes the patient to infection, pneumonia, and atelectasis, or collapse of alveoli. Atelectasis reduces gas exchange and causes intolerance of anesthesia. It is also a common problem after general anesthesia. Oh my god, all my stuff's falling. Chronic lung problems such as asthma, emphysema, and chronic bronchitis also reduce the elasticity of the lungs, which reduces gas exchange. As a result, patients with these problems have reduced tissue oxygenation. Previous surgical procedures and anesthesia affect the patient's readiness for surgery. Previous experiences, especially with complications, may increase anxiety about the scheduled surgery. Ask the patient about patient's experience with anesthesia and all allergies. These data provide information about tolerance and possible fears about the use of anesthesia. Okay, these data provide information about tolerance of and possible fears about the use of anesthesia. The family medical history and problems with anesthetics may indicate possible reactions to anesthesia, such as malignant hyperthermia. See Chapter 17. A sensitivity or allergy to certain substances alerts you to a possible reaction to anesthetic agents or to substances that are used before or during surgery. For example, povidone iodine, e.g. betadine, used for skin cleansing, contains the same allergens found in shellfish. Patients who are allergic to shellfish may have an adverse reaction to povidone iodine or betadine. The patient with an allergy to bananas and other fruits often also have a latex allergy. Blood donation for surgery can be made by the patient, which is called autologous donations, a few weeks just before the scheduled surgery date. Then, if blood is needed during or after surgery, an autologous blood transfusion can be given. This practice eliminates transfusion reactions and reduces the risk of acquiring bloodborne disease. Patients can donate their own blood up to 5 weeks before surgery if they are infection-free, have a hemoglobin level greater than 11 grams, or 110 grams per liter, 11 grams per deciliter, I guess, and 110 grams per liter, and have a physician's recommendation. Patients with cardiac disease may need additional clearance from their cardiologist before making an autologous donation. The physician may prescribe supplemental iron before the first donation. Autologous donations can be made as often Autologous donations can be made as often as every 3 days if other criteria are met. Usually a total of 2 to 4 units are donated. The last donation cannot be made within 72 hours before surgery. A special tag is placed on the blood bag when an autologous blood donation has been made. The blood donor center gives the patient a matching tag that he or she wears or brings to the surgical area before surgery. This procedure helps ensure that patients receive only their own blood. If the blood is not used, some agencies discard it. In other agencies, the blood goes to the blood bank, where it is processed into various blood components, e.g. plasma, packed cells, and platelets. Patients may wish to have their family and friends donate blood exclusively for their use, if needed. This practice, called directed blood donation, is possible only if the blood types are compatible and the donor's blood is acceptable. Patients may fear disease transmission from unknown blood and feel more comfortable knowing who gave the blood. Many centers do not accept directed blood, stating that it gives a false sense of security. As with autologous blood donations, a special tag is attached to the blood bag. This tag notes the names of the patient and the donor and bears the patient's signature. Ask whether autologous or directed blood donations have been made, and document this information in the chart. It is important to know the specific blood collection center where the donation was made, and whether the blood has arrived before the patient goes into surgery. The hospital receives and stores the blood units until they are used or are no longer needed. Unused blood is returned to the collection center. Increased use of the bloodless surgery and minimally invasive surgery provides alternatives for patients with religious or medical restrictions to blood transfusions. These programs reduce the need for transfusion during and after surgery. Some techniques used include limiting blood samples, the number of samples as well as the volume of blood drawn per sample before surgery, and stimulating the patient's own red blood cell production with epoetin alpha or epigen, procrit, before, during, and after surgery. Supplemental iron, folic acid, vitamins B12, and vitamin C may be prescribed before surgery to help red blood cell formation. Newer equipment and surgical techniques cause less blood loss than older techniques. Such advances include recycling blood suctioned during surgery and immediately transfusing it back into the patient. Assess, monitor, teach, and support the patient during the bloodless surgery process. Discharge planning is stated before surgery. Assess the patient's home environment, self-care capabilities, and support systems, and anticipate postoperative needs before surgery. All patients, regardless of how minor the surgery or how often they have had surgery, should have discharge planning. Older patients and dependent adults may need transportation referrals to and from the physician's office or the surgical setting. A home care nurse may be needed to monitor recovery and to provide instruction. All patients with few support systems may need follow-up care at home. Some patients need a planned direct admission to a rehabilitation hospital or center for physical therapy after surgery, e.g. a total hip replacement. Shortened hospital stays require adequate discharge planning to achieve the desired outcomes after surgery. Physical assessment / clinical manifestations. The preoperative patient may be any age with a health status that varies from well to debilitated. Perform a complete assessment before surgery to obtain baseline data. During assessment, identify current health problems, potential complications related to amnesia, and possible complications that may occur after surgery. When beginning assessment, obtain a complete set of vital signs. You may need to obtain vital signs several times at different time intervals for accurate baseline values. Previous vital signs from another admission, if available, are helpful to compare with current vital signs. Abnormal vital signs may require postponement of surgery until the problem is treated and the patient's condition is stable. Also, assess for anxiety, which could increase blood pressure, pulse, and respiratory rate. Document these findings as part of the overall assessment. Throughout the physical assessment, focus on problem areas identified from the patient's history and on all body systems affected by the surgical procedure. The older adult, chart 16.2, see also chapter 3, or chronically ill patient is at increased risk for complications during and after surgery. The number of serious problems, morbidity, and deaths, mortality, during or after surgery is higher in older and chronically ill patients. Chart 16.2. Nursing focus on the older adult. Specific considerations when planning care for the older preoperative patient. Greater incidence of chronic illness, greater incidence of malnutrition, more allergies, increased incidence of impaired self-care abilities, inadequate support systems, decreased ability to withstand the stress of surgery and anesthesia, increased risk for cardiopulmonary complications after surgery, risk of change in mental status when admitted, e.g., related to familiar surroundings, change in routine, drugs, increased risk of fall and resultant injury. Back to the text. Report any abnormal assessment findings to the surgeon and to anesthesia personnel. In this way, you are a proactive patient advocate exercising professional legal responsibility. Often, established protocols or care maps identify what interventions are to be performed before surgery. Cardiovascular status is critical to assess because cardiac problems may cause as many as 30% of surgery-related deaths. Check the patient for hypertension, which is common. It is often undiagnosed and can affect the response to surgery. Cardiac assessment includes listening to heart sounds for rate, regularity, and abnormalities. Examine the patient's hands and feet for temperature, color, peripheral pulses, capillary refill, and edema. Report any problems, e.g. absent peripheral pulses, pitting edema, cardiac symptoms such as chest pain, shortness of breath, and dyspnea, to the physician for further assessment and evaluation. Cardiac assessment is discussed further in Chapter 35. Respiratory status considers age, smoking history, including exposure to secondhand smoke, and any chronic illness. Observe the patient's posture, respiratory rate, rhythm, and depth, overall respiratory effort, and lung expansion. Document any clubbing of the fingertips, swelling at the base of the nail beds caused by a chronic lack of oxygen, or cyanosis. Auscultate the lungs to assess for any abnormal breath sounds, crackles, wheezes, rubs. More information on respiratory assessment is found in Chapter 29. Renal status and function affect the excretion of drugs and waste products, including anesthetic and analgesic agents. If renal function is reduced, fluid and electrolyte balance can be altered, especially in older patients. Ask about problems such as urinary frequency, dysuria or painful urination, nocturia, awakening during nighttime sleep because of a need to void, and difficulty starting urine flow, and oliguria, scant amount of urine. Ask the patient about the appearance and odor of the urine. Equally important is an assessment of usual fluid intake and degree of continence. If the patient has renal or urinary problems, consult with the physician about further workup. Renal/urinary assessment is discussed further in Chapter 68. Kidney impairment decreases the excretion of drugs and anesthetic agents. As a result, drug effectiveness may be altered. Scopolamine or buscopan, morphine, meperidine or Demerol, and barbiturates often cause confusion, disorientation, apprehension, and restlessness when given to patients with decreased kidney function. Neurologic status includes the patient's overall mental status, level of consciousness, orientation, and ability to follow commands. This information is needed before planning preoperative teaching and care after surgery. A problem in any of these areas affects the type of care needed during the surgical experience. Determine the patient's baseline neurologic status to be able to identify changes that may occur later. Also assess for any motor or sensory deficits. See Chapter 43 for complete nervous system assessment. The usual neurologic status of a mentally impaired patient may be difficult to assess. The patient who has been independent and oriented at home may become disoriented in the hospital setting. Family members can often provide information about what the patient was like at home. Ensure patient safety by assessing the patient's risk for falling, especially the older patient. Evaluate factors such as mental status, muscle strength, steadiness or of gait, and sense of independence to determine the patient's risk. Document the patient's ability to ambulate and the steadiness of gait as baseline data. Musculoskeletal status problems may interfere with positioning during and after surgery. For example, patients with arthritis may be able to assume surgical positions but have discomfort after surgery from prolonged joint immobilization. Other anatomic features, such as the shape and length of the neck and the shape of the chest cavity, may interfere with respiratory and cardiac function, or require special positioning during surgery. Ask about a history of joint replacements and document the exact location of any prosthesis. During surgery, ensure that electrocautery pads, which could cause an electrical burn, are not placed on or near the area of prosthesis. Nutritional status, especially malnutrition and obesity, can increase surgical risk. Surgery increases metabolic rate and depletes potassium, vitamin C, and B vitamins. Surgery increases metabolic rate and depletes potassium, vitamin C, and B vitamins, all of which are needed for wound healing and blood clotting. In malnourished patients, decreased serum protein levels slow recovery. Negative nitrogen balance may result from depleted protein stores. This problem increases the risk for skin breakdown, delayed wound healing, possible dehiscence or evisceration, see Chapter 18, dehydration, and sepsis. Some older patients may have poor nutrition because of chronic illness, diuretic or laxative use, poor dietary planning or habits, anorexia, and lack of motivation or financial limitations. Indications of poor fluid or nutritional status include brittle nails, muscle wasting, dry or flaxy skin, decreased skin turgor and hair changes, e.g. dull or sparse, dry, orthostatic or postural hypotension, decreased serum protein levels, and abnormal serum electrolyte values. The obese patient is often malnourished because of an imbalanced diet. Obesity increases the risk for poor wound healing because of excessive adipose or fatty tissue. Fatty tissue has few blood vessels, little collagen, and decreased nutrients, all of which are needed for wound healing. Obesity stresses the heart and reduces the lung volumes, which can affect the surgery and recovery. In addition, obese patients may need larger doses of drugs and may retain them longer after surgery. Psychosocial assessment. Perform a psychosocial assessment to determine the patient's level of anxiety, coping ability, and support systems. Provide information and offer support as needed. Most patients have some degree of anxiety before surgery. Others may be fearful. The extent of these reactions varies according to the type of surgery, the perceived effects of the surgery and its potential outcome, and the patient's personality. Surgery may be seen as a threat to life, body image, self-esteem, self-concept, or lifestyle. Patients may fear death, pain, helplessness, or change in role of work status. A diagnosis of life-threatening conditions, possible disabling or crippling effects, or the unknown. Anxiety or fear affects the patient's ability to learn, cope, and cooperate with teaching and operative procedures. Anxiety may also influence the amount and type of anesthetic needed and may slow recovery. In addition, severe preoperative anxiety appears to increase the degree of pain some patients have after surgery. See the evidence-based practice box on page 249. Be aware of potential anxiety when interviewing the patient and planning teaching. Assess coping mechanisms used by the patient under similar situations or in the past when confronted with a stressful situation. Ask open-ended questions about the patient's feelings about the entire surgical experience. Factors that influence coping include age, previous surgical or sick role experiences, and emotional and physical signs of fear, anxiety or discomfort. Signs of anxiety include anger, crying, helplessness, profuse sweating, increased pulse rate, palpitations, sleeplessness, diarrhea, and urinary frequency. Laboratory assessment. Laboratory tests before surgery provide baseline data about the patient's health and help predict potential complications. The patient scheduled for surgery in an ambulatory surgical center or admitted to the hospital on the morning of or day before surgery may have pre-admission testing, or PAT, performed from 24 hours to 28 days before the scheduled surgery. These test results are usually valid unless there have been a change in the patient's condition that warrants repeated testing or the patient is taking drugs that can alter laboratory values, e.g. warfarin, aspirin, and diuretics. Some facilities have time limits for tests, especially pregnancy testing or any other test results that would require altering the surgical plan. The choice of laboratory testing before surgery varies among facilities and depends on the patient's age, medical history, and type of anesthesia planned. The most common tests include urine analysis, blood type and screen, complete blood count or hemoglobin level and hematocrit, clotting studies, prothrombin time, PT, international normalized ratio, INR, activated partial thromboplasm time, or APTT, platelet count, electrolyte levels, serum creatinine, and creatinine. Creatinine? Yeah. No. Creatinine. I hate that word. And blood urea nitrogen levels. Depending on a female patient's age and the nature of the planned procedure, a pregnancy test may also be needed. Evidence-based practice. Relationship between anxiety and postoperative pain is controversial. Does preoperative anxiety level predict postoperative pain? Nurses have been taught that anxiety can have an impact on a patient's perception of pain. The first study exploring the influence of anxiety on surgical recovery was conducted in 1958. This concept has provided the rationale for preoperative teaching, relaxation techniques, and medication. However, the evidence linking high levels of preoperative anxiety to increased pain levels after surgery has shown conflicting results. A variety of research reports and previous meta-analyses regarding preoperative anxiety and postoperative factors were examined for study design, numbers of subjects, methodology, and control variables. These studies employed different designs and often used different instruments to measure anxiety and pain. Few studies also examined the level of pain in the preoperative period. Some studies using an experimental design compared the anxiety levels and postoperative pain levels in patients who received anti-anxiety drugs in the preoperative period with patients who did not receive such drugs. For those studies that did not use anti-anxiety drugs, a statistical difference was seen with patients having higher levels of preoperative anxiety, especially state anxiety, also having higher levels of pain or using higher amounts of analgesics in the postoperative period than those patients with lower preoperative anxiety. Level of evidence. 3. The study is a report of a meta-analysis of previous research on the topic of preoperative anxiety and postoperative pain. Commentary. Implications for practice and research. Although anxiety reduction techniques can include drug therapy, there are many non-pharmacologic ways to help reduce anxiety. Many of these are considered nursing interventions which can be low risk to the patient. Therefore, although the authors of this meta-analysis identify the need for large prospective unified design, intervention studies examining the influence of preoperative anxiety on the level of post-operative pain among surgical patients, they also advocate the continued use of nursing strategies to lower anxiety among patients during the perioperative experience. Okay, urinalysis, this is back to the text. Urinalysis is performed to assess abnormal substances in the urine, such as protein, glucose, blood, and bacteria. If kidney disease is suspected, or if the patient is older, the physician may request other tests to determine the type and degree of disease present. Report electrolyte imbalances or other abnormal results to the anesthesia team and the surgeon before surgery. Hypokalemia, decreased serum potassium level, increases the risk for toxicity if the patient is taking digoxin, slows recovery from anesthesia, and increases cardiac irritability. Hyperkalemia, increased serum potassium level, increases the risk of dysrhythmias, especially with the use of anesthesia. Potassium problems must be corrected before the surgery. Other studies may be needed depending on the patient's medical history. For example, baseline ABG values are assessed before surgery for patients with chronic pulmonary problems. Chart 16.3 lists abnormal laboratory findings and their possible causes. Imaging assessment. A chest X-ray may be requested before surgery. Often young, healthy adults are not required to have a chest X-ray. A chest X-ray determines the size and shape of the heart, lungs, and major vessels, and determines the presence of pneumonia or tuberculosis. It also provides baseline data in case of complications. Abnormal X-ray findings alert the surgeon to potential cardiac or pulmonary complications. Heart failure, cardiomyopathy, pneumonia, or infiltrates may cause cancellation or delay of elective surgery. For emergency surgery, X-ray results assist the anesthesia provider in selecting anesthesia. Other imaging studies are based on patient need, medical history, and the nature of the surgical procedure. For example, a patient with back pain may have computed tomograph, CT, or magnetic resonance imaging (MRI) examinations before spinal surgery to identify the exact location of the problem. Other diagnostic assessment. An ECG may be required for all patients older than a specific age who are to have general anesthesia. The age varies among facilities but is often 40 to 45 years. An ECG may also be ordered for patients with a history of cardiac disease or those at risk for cardiac complications. It provides baseline information on new or existing cardiac problems, such as an old myocardial infarction. A patient with a known cardiac problem may need a cardiology consultation before surgery. Drugs for problem prevention, such as nitroglycerin and antibiotics, may be needed throughout the surgical period to reduce or prevent stress on the heart. Abnormal or potentially life-threatening ECG results may cause the cancellation of surgery until the patient's cardiac status is stable. A focused assessment of the preoperative patient is shown in chart 16.4. Here's a quick NCLEX examination challenge. While the nurse is taking the client's history before elective cosmetic surgery, the client reports all of the following facts. Which ones should be reported to the surgeon and may result in cancellation of the surgery? A. She delivered a baby 8 weeks ago and still has some vaginal discharge. B. She has 3 large boils or furuncles on the skin of her left shoulder. C. She has been taking oral contraceptives for the last 2 weeks. Or D. She is allergic to aspirin, dust, peanuts, and fall pollens. And I don't know the answer, so look it up in the book. I have no clue. Chart 16.3, laboratory profile, perioperative assessment. Test. Potassium. Normal range, 3.5 to 5. It's increased in dehydration, renal failure, acidosis, cellular / tissue damage, hemolysis of the specimen. It's decreased in NPO status when potassium replacement is inadequate. That's right. Excessive use of non-potassium sparing diuretics, vomiting, malnutrition, diarrhea, and alkalosis. Sodium. 90-year-old or younger. Okay. 136 to 145 is what it says here. Older than 90. Okay, so if they're younger than 90 years old, then 136 to 145. If they're older, then it should be 132 to 146. So I have a wider margin there. Too much. Hypernatremia, cardiac, or you see it in cardiac or renal failure, hypertension, excessive amounts of IV fluids containing normal saline, edema, dehydration, or hemoconcentration. Too little, you'll see it can happen with nasogastric drainage, vomiting or diarrhea, excessive use of laxatives or diuretics, excessive amounts of IV fluids containing water, syndrome of inappropriate antidiuretic hormone, or SIADH. SIADH. Okay. Chloride. For 90-year-olds or younger, it's 98 to 106, and older than 90, it's 98 to 111. And you'll see this with respiratory alkalosis, dehydration, renal failure, excessive amounts of IV fluids containing sodium chloride, and that's too much, or an excess. And then you'll see too little with excessive nasogastric drainage, vomiting, excessive use of diuretics, diarrhea. Carbon dioxide. For 60 years or younger, it should be 23 to 30. And for 60 to 90, it should be 23 to 31. And older than 90, it should be 20 to 29. Too much CO2, you got chronic pulmonary disease, intestinal obstruction can happen with it, vomiting or nasogastric suctioning, and metabolic alkalosis. If they have too little carbon dioxide, it could be because of hyperventilation, diabetic ketoacidosis, diarrhea, lactic acidosis, renal failure, or salicylate toxicity. Glucose. For 60 year or younger, it's going to be 70 to 110. 60 to 90 is going to be 82 to 115 for your glucose, and that's a fasting. It should be a fasting number. Older than 90 is 75 to 121. So too much, watch for hyperglycemia. Excessive amounts of IV fluids containing glucose, stress, steroid use, pancreatic or hepatic disease. And too little, it would be excess insulin. You've taken too much insulin. Creatine for females, or creatinine. Creatinine? Alright. 60 year or younger, be 0.5 to 1.1. 60 to 90 is going to be 0.6 to 1.2. And older than 90 is 0.6 to 1.3. Males, 60 or younger, 0.6 to 1.2. 60 to 90, 0.8 to 1.3. And older than 90, 1 to 1.7. Jeez. Okay, renal damage with excess creatinine might be caused by renal damage with destruction of large number of nephrons, renal insufficiency, acute renal failure, chronic kidney disease, end-stage kidney disease, or ESKD. And too little might be caused by atrophy of muscle tissue. Blood urea nitrogen bun. Younger than 60 should be 10 to 20. 60 to 90, 8 to 23. Older than 90, 10 to 31. And dehydration might cause an excess, a high bun, renal failure, excessive protein in diet, liver failure. A depletion or a low bun would be overhydration or malnutrition. Prothrombin time, 12.5 seconds, 85 to 100%, or 1 to 1.1 patient control ratio. Okay, a high PT is going to be coagulation defect or bleeding disorder they might have. A low PT, they might have coagulation disorder or clotting disorder, such as thrombophlebitis or pulmonary embolus. Okay, INR should be 0.7 to 1.8. Wow, just one number, thank God. And high INR could be caused by anticoagulant therapy, aspirin, warfarin. Low could be extensive cancer. APTT is 30 to 40 seconds. And if it's high, it may be because of coagulation defect, bleeding disorder, or anticoagulant therapy like heparin or liver disease. If it's low, then it could be a coagulation disorder such as thrombophlebitis or pulmonary embolus. Also, extensive cancer or immune disorder. So pretty much the same as the last one. A little more, though. White blood total. Oh, wait, no. The immune disorder goes with the white blood one. So white blood cell count, 5,000 to 10,000. Excuse me. Inflammation, and a high WBC would be inflammation, stress, tissue necrosis. A low might be an immune disorder. Also, did I say infection? Infection, okay. But low might be an immune disorder, immunosuppressant therapy. Okay. Hemoglobin. Females, total 18 to 44-year-old females should be 12 to 16. Or 117 to 155 grams per liter. It would be 12 to 16 grams per deciliter, or 117 to 155 grams per liter. 45 to 64-year-old female would be 11.7 to 16 grams per deciliter. 65 to 74 is, oh geez, just give me a basic number. Males is 18 to 44, or males is 14 to 18. 18 to 44, 45 to 64 is 13.1 to 17.2. That's all I'm going to do. And then a high hemoglobin would be dehydration, polycythemia, chronic pulmonary disease, congestive heart failure. A low hemoglobin could be because of blood loss, anemia, or renal failure. Oh my God, last one, hematocrit. Females 18 to 44, 35 to 45%, 45 to 75 would be 37 to 47%. Big difference, huh? Males 18 to 44, 42 to 52%, and 64 to 74 would be 65 to 74 would be 37 to 51%. So somewhere around, females is 35 to 45% ish, and males is 42 to 52% ish. High hematocrit could be because of dehydration, polycythemia, high altitude. Low hematocrit could be because of blood loss, anemia, or renal failure, just like the hemoglobin. Oh, more charts. Okay, chart 16.4, focused assessment. The preoperative patient. As part of the cardiopulmonary assessment, take and record vital signs. Report hypotension or hypertension, heart rate less than 60 or more than 120 beats a minute, irregular heart rate, chest pain, shortness of breath or dyspnea, tachypnea, pulse oximetry reading of less than 94%. Assess for and report any signs or symptoms of infection, including fever, purulent sputum, dysuria or cloudy, foul-smelling urine, any red, swollen, draining IV or wound site, increased white blood cell count. Assess for and report signs or symptoms that could contraindicate surgery, including increased PT, INR or APTT, hypokalemia or hyperkalemia, patient report of possible pregnancy or positive pregnancy test. Assess for and report other clinical conditions that may need to be evaluated by a physician or advanced nurse practitioner before proceeding with the surgical plans, including change in mental status, vomiting, rash, recent administration of an anticoagulant drug. Analysis. Common nursing diagnoses and collaborative problems. Priority nursing diagnoses for preoperative patients are 1. Deficient knowledge, specific experiences before, during, and after surgery, related to unfamiliarity with available resources. 2. Anxiety related to the threat of a change in health status or fear of the unknown. Additional nursing diagnoses. Additional nursing diagnoses and collaborative problems. In addition to the common nursing diagnoses, preoperative patients may have one or more of these. Sleep deprivation related to internal sensory alterations, e.g. illness, anxiety. Ineffective coping related to the impending surgery. Grieving related to the effects of surgery. Disturbed body image related to anticipated changes in the body's appearance or function. Compromised family coping related to temporary family disorganization and role changes. Powerlessness related to the healthcare environment. Loss of independence and loss of control of one's body. Planning and implementation. As the nurse, your role is to ensure coordination of care for the patient before surgery. This responsibility continues until the patient is transferred to the OR. Deficient knowledge. Planning. Expected outcomes. Knock. The patient needs to know what to expect during and after surgery and participate in his or her recovery as indicated by consistently demonstrating these behaviors. Explaining the purpose and expected results of the planned surgery, asking questions when a team or procedure is not known, adhering to the NPO requirements, stating an understanding of preoperative preparations, e.g. skin preparation, bowel preparation, demonstrating correct use of exercises and techniques to be used after surgery for prevention of complications, e.g. splinting the incision, coughing, deep breathing, performing leg exercises, ambulating as early as permitted. Interventions. Because the surgical experience is foreign to many people, focus on teaching the patient and family members. Teaching may begin in the surgeon's office for planned or elective surgery. Pamphlets, written instructions, and videotapes and DVDs may be given or sent to the patient. More teaching may occur when the patient has pre-admission testing. Some facilities hold classes before surgery for groups of patients or show videos for those who are having the same or similar surgical procedures. A tour of the operating suite and the post-anesthesia care unit, or PACU, may be included. Explore the patient's level of knowledge and understanding Increased access to information via the internet may be helpful, but is also a concern. Some internet information may not be accurate or may not apply to a specific patient's plan of care. Information about informed consent, dietary restrictions, specific preparation for surgery, bowel and skin preparations, exercise after surgery, and plans for pain management promote patients' participation and help achieve the desired outcome. A sample educational checklist is shown in Table 16.4. Because education occurs in a variety of settings, coordination of patient teaching efforts is challenging. When you care for the patient just before surgery, same-day ambulatory surgery, outpatient unit, inpatient hospital unit, assess the patient's and family members' knowledge and provide additional information as needed. Document in the patient record information about who was involved in teaching, what specifically was taught, and what education materials were given to the patient and family. Ensuring informed consent. Surgery of any type involves invasion of the body and requires informed consent from the patient or legal guardian, Figure 16.1. Patients deserve and rightly demand to be informed and involved in decisions affecting their health care. Consent implies that the patient has sufficient information to understand the nature of and reason for surgery, who will be performing the surgery, and whether others will be present during the procedure, e.g. students, all available options and the risks associated with each option, the risks associated with the surgical procedure and its potential outcomes, the risks associated with the use of anesthesia. Informed consent is one way to help ensure patient safety. It helps protect the patient from any unwanted procedures and protects the surgeon and the facility from lawsuit claims related to unauthorized surgery or uninformed patients. Written record of informed consent is documented on a consent form, but can also be documented in the surgeon's notes. The consent form documents the patient's consent and signature for the procedure listed. As a competent adult, it is the patient's right to refuse treatment for any reason, even when refusal might lead to death. For example, in the case of Jehovah's Witnesses, some patients will not accept blood transfusions because of their religious convictions. The surgeon is responsible for having the consent form signed before sedation is given and before surgery is performed. You, as a nurse, are not responsible for providing detailed information about the surgical procedure. Rather, your role is to clarify facts that have been presented by the physician and dispel myths that the patient or family may have about the surgical experience. You verify that the consent form is signed, and you serve as a witness to the signature, not to the fact that the patient is informed. If you believe that the patient has not been adequately informed, contact the surgeon and request that he or she see the patient for further clarification. Document this action in the chart. Table 16.4 Preoperative Teaching Checklist. Consider these items when planning individualized preoperative teaching for patients and families. Fears and anxieties, surgical procedure, preoperative routines, e.g. NPO, blood samples, and showering, invasive procedures, e.g. lines and catheters, coughing, turning, deep breathing, incentive spirometer, how to use, how to tell when used correctly, lower extremity exercises, stockings and pneumatic compression devices, early ambulation, splinting, and pain management. Patients who cannot write may sign with an X, which must be witnessed by two persons. In an emergency, telephone or telegram authorization is acceptable and should be followed up with written consent as soon as possible. The number of witnesses, usually two, and the type of documentation vary according to the facility's policy. In a life-threatening situation in which every effort has been made to contact the person with medical power of attorney, consent is desired but not essential. In place of written or oral consent, written consultation by at least two physicians who are not associated with the case may be requested by the physician. This formal consultation legally supports the decision for surgery until the appropriate person can sign a consent form. If the patient is not capable of giving consent and has no family, the court can appoint a legal guardian to represent the patient's best interests. A blind patient may sign his or her own consent form, which usually needs to be witnessed by two persons. Patients who have English as a second language, ESL, who do not speak the general language of the facility, or who are hearing impaired, may require a qualified translator and a second witness. Many facilities have consent forms written in more than one language and also have healthcare professionals who are proficient with American Sign Language. Qualified translators may be healthcare professionals, other types of hospital employee, or family members. They are required to keep patient information confidential. Some surgical procedures, such as intraocular lens implants, sterilization, and experimental procedures, may require a special permit in addition to the standard consent. National and local governing bodies and the individual facility determine which procedures require a separate permit. Separate consents for anesthesia and blood products may be required. Surgical procedures that are site-specific, such as left, right, or bilateral, require patient identification before surgery. The patient is asked to mark the site with a marker to ensure the correct site is used and the wrong site is avoided. The nurse is an important part of this safety measure. Before starting the operative procedure, several facilities are adopting a timeout procedure. At a minimum, the patient's identity, correct side and site, correct patient position, agreement on the proposed procedure, and the availability of correct implants and equipment must be verified by all members of the surgical team. The perioperative nurse is in a position of ensuring these safety measures are again implemented immediately before the procedure is started. Patient self-determination. Patients receiving medical care have the right to have or to initiate advance directives, such as a living will or durable power of attorney, as mandated by the Patient Self-Determination Act. Advance directives provide legal instruction to the healthcare providers about the patient's wishes and are to be followed. Surgery does not provide an exception to a patient's advance directives or living will. Chapter 9 discusses advance directives in more detail. Implementing dietary restrictions. Regardless of the type of surgery and anesthesia planned, the patient is restricted to NPO status before surgery. NPO means no eating, drinking, including water, or smoking. Nicotine stimulates gastric secretions. The exact amount of time a patient must be NPO before surgery is controversial. Patients, especially older adults who fast for 8 or more hours, may have imbalances of fluid, electrolytes, and blood glucose levels. The American Society of Anesthesiologists, the ASA, recommends a reduced NPO time, 6 or more hours for easily digested solid food and 2 hours for clear liquids. NPO status ensures that the stomach contains a limited volume of gastric secretions, which decreases the risk for aspiration. Outpatients and patients who are scheduled for admission to the hospital on the same day that surgery is performed must receive written and oral instructions about when to begin NPO status. Emphasize the importance of adherence. Failure to adhere can result in cancellation of surgery or increase the risk for aspiration during or after surgery. Administering regular scheduled drugs. On the day of surgery, the patient's usual drug schedule may need to be altered. Consult the medical physician and the anesthesia provider for instructions about drugs such as those taken for diabetes, cardiac disease, or glaucoma as well as regularly scheduled anticonvulsants, hypertensives, and anticoagulants, antidepressants, and corticosteroids. The physician may prescribe some drugs, including over-the-counter drugs such as aspirin and herbal supplements, to be stopped until after surgery. Other drugs may be given IV to maintain the drug level in the blood. Drugs for cardiac disease, respiratory disease, seizures, and hypertension are commonly allowed with a sip of water before surgery. Some antihypertensives or antidepressant drugs are withheld on the day of surgery to reduce adverse effects on blood pressure during surgery. The diabetic patient who takes insulin may be given a reduced dose of intermediate or long-acting insulin based on the blood glucose level, or may be given regular fast-acting insulin in divided doses on the day of surgery. As an alternative, an IV infusion of 5% dextrose in water may be given with the insulin to prevent low blood sugar during surgery. Because of the many treatment approaches to diabetes, clarify drug and IV prescriptions with the physician. See Chapter 67 for more information about diabetes. Intestinal preparation. Bowel or intestinal preparations are performed to prevent injury to the colon and to reduce the number of intestinal bacteria. Evacuation of the bowel is needed when a patient is having major abdominal, pelvic, perineal, or perianal surgery. The surgeon's preference and the type of surgical procedure determine the type of bowel preparation. An enema ordered to be given until return flow is clear is a stressful procedure, especially for the older patient. Repeated enemas can cause electrolyte imbalance, fluid volume imbalances, vagal stimulation, and postural orthostatic hypertension. Enemas also cause severe anorectal discomfort in patients with hemorrhoids. Some physicians prescribe potent laxatives, e.g. polyethylene glycol electrolyte solutions, or go lightly instead of enemas, especially for older patients. Bowel preparations can be exhausting, and you must take safety precautions to prevent falls. Skin preparation. The skin preparation may be embarrassing or uncomfortable for the patient, especially if the surgical site is in a sensitive or private body area. Provide a warm, comfortable, and private environment during the procedure. The skin is the body's first line of defense against infection. A break in this barrier increases the risk for infection, especially for older patients. Skin preparation before surgery is the first step in prevention of surgical wound infection. 1 or 2 days before the scheduled surgery, the surgeon may ask the patient to shower using an antiseptic solution. Instruct the patient to be especially careful to clean around the proposed surgical site. If the patient is hospitalized before surgery, showering and cleaning are repeated the night before surgery or in the morning before transfer to the surgical suite. This cleaning reduces contamination of the surgical field and reduces the number of organisms at the site. Remove any soil or debris from the surgical site and surrounding areas. Factors that predispose to wound contamination include bacteria found in hair follicles, disruption of the normal protective mechanisms of the skin, and nicks in the skin. Shaving of hair creates the potential for infection. Hair clipping with electrical clippers is often used to decrease the problems caused by traditional razors. The Centers for Disease Control and Prevention, CDC, recommends that if shaving is necessary, the hair should be removed using disposable sterile supplies and antiseptic principles immediately before the start of the surgical procedure. If needed, shaving is performed in the treatment room, the holding area of the operating suite, or the operating room, OR. Figure 16.2 shows areas shaved for various surgical procedures. Shaving is considered an inappropriate hair removal method. Beginning in 2010, only clippers or depilatories are to be used for hair removal. Depilatories, whatever that is. Preparing the patient for tubes, drains, and vascular access. Prepare the patient for possible placement of tubes, drains, and vascular access devices. Preparation reduces the patient's anxiety and fear and the family's negative reaction. Be careful not to scare the patient while providing information about the purpose of each tube. Tubes of all sorts are common after surgery. The patient may need an indwelling urinary or Foley catheter before, during, or after surgery to keep the bladder empty and to monitor kidney function. The patient having abdominal or genitourinary surgery usually has a Foley catheter. A nasogastric or NG tube may be inserted before abdominal surgery to decompress or empty the stomach and the upper bowel. More often, however, the tube is placed after the induction of anesthesia when insertion is less disturbing to the patient and is easier to perform. Drains are often placed during surgery to help remove fluid from the surgical site. Some drains are under the dressing, others are visible and require emptying. Drains come in various shapes and sizes. See Chapter 18. Inform the patient that drains are often used routinely and that generally they are not painful but may cause some discomfort. Discuss the reasons drains should not be kinked or pulled. Vascular access is placed for patients receiving a general anesthetic and most patients receiving other types of anesthetics. Access is needed to give drugs and fluids before, during, and after surgery. Patients who are dehydrated or are at risk for dehydration may receive fluids during surgery. Considerations for older adults. Older adult patients are at greater risk for dehydration because their fluid reserves are lower than those of young or middle-aged adults. Carefully monitor older and adult patients and patients with cardiac disease receiving IV fluids. See Chapter 15 for more information. The IV access is usually placed in the arm using a large short catheter, e.g. 18 gauge 1-inch catheter, or placed in the back of the hand using a smaller 20 gauge catheter. A larger vein provides the least resistance to fluid or blood infusion, especially in an emergency when rapid infusion may be needed. Depending on the patient's needs and the facility's policies, the IV access can be placed before surgery when the patient is in the hospital room, in the holding or admission area of the surgical suite, or in the OR. Postoperative procedures and exercises. Teach the patient and family members about exercises and procedures, e.g. checking dressings, obtaining vital signs frequently, to be performed after surgery. Family members can be helpful in reminding patients to perform these exercises. Teaching before surgery reduces apprehension and fear, increases cooperation and participation in care after surgery, and decreases respiratory and vascular complications. When the fear or anxiety level is high, explore the patient's feelings about discussing procedures. Discussion, demonstration with return demonstration, and practice by the patient aid in the ability to perform various breathing, Chart 16.5, and leg, Chart 16.6, exercises after surgery. Stress the need to begin exercises early in the recovery phase and to continue them with 5 to 10 repetitions each, every 1 to 2 hours after surgery for at least the first 48 hours. Explain that the patient may need to be awakened for these activities. Procedures and exercises to prevent respiratory complications. Breathing exercises include deep or diaphragmatic breathing to enlarge the chest cavity and expand the lungs. After you demonstrate and explain the technique, urge the patient to practice the 5 steps of deep breathing. For patients with chronic lung disease or limited chest expansion, as seen in older patients because of the aging process, expansion breathing exercises are useful. For the patient having chest surgery, expansion breathing exercises strengthen accessory muscles and are started before surgery. Expansion breathing may be used after surgery during chest physiotherapy, percussion, vibration, postural drainage, to help loosen secretions and maintain an adequate air exchange. Incentive spirometry is another way to encourage the patient to take deep breaths. Its purpose is to promote complete lung expansion and to prevent pulmonary problems. Various types of incentive spirometers are available. Figure 16.3 shows a patient using one type. With all types, the patient Must be able to seal the lips tightly around the mouthpiece, inhale spontaneously, and hold his or her breath for 3 to 5 seconds for effective lung expansion. Goals, e.g., attaining specific volumes, can be set according to the patient's ability and the type of incentive spirometer. Seeing a light move up a column or a bellows expanding reinforces and motivates the patient to continue performance. Alright, figure 16.2, skin preparation of common surgical sites. Shaded areas indicate preparation. So head surgery, is this, you would prepare everything around the face except the face and the back down to the upper shoulders. No. Ooh, God. No, I'm just going to skip all that. You can look at that. Patient and Family Education Guide. Preoperative or perioperative respiratory care. Deep diaphragmatic breathing. 1. Sit upright on the edge of the bed or in a chair, being sure that your feet are placed firmly on the floor or a stool. After surgery, deep breathing is done with the patient in high Fowler's position or in semi-Fowler's position. Take a gentle breath through your mouth. Breathe out gently and completely. Then take a deep breath through your nose and mouth, and hold this breath to the count of 5. Exhale. Exhale through your nose and mouth. Expansion breathing. Find a comfortable upright position with your knees slightly bent. Bending the knees decreases tension on the abdominal muscles and decreases respiratory resistance and discomfort. 2. Place your hands on each side of your lower rib cage, just above your waist. Take a deep breath through your nose, using your shoulder muscles to expand your lower rib cage outward during inhalation. Inhale, concentrating first on moving your chest, then on moving your lower ribs inward, while gently squeezing the rib cage and forcing out air of the base of your lungs. Making me yawn. Splinting of the surgical incision. Unless coughing is contraindicated, place a pillow, towel, or folded blanket over your surgical incision and hold the item firmly in place. Take 3 slow, deep breaths to stimulate your cough reflex. Inhale through your nose and then exhale through your mouth. On your 3rd deep breath, cough to clear secretions from your lungs while firmly holding the pillow, towel, or folded blanket against your incision. Chart 16.6, Patient and Family Education Guide. Postoperative leg exercises. Exercise number 1. Lie in bed with the head of your bed elevated to 45 degrees. Beginning with your right leg, bend your knee, raise your foot off the bed, and hold this position for a few seconds. Extend your leg by unbending your knee and lower the leg to the bed. Repeat this sequence 4 more times with your right leg, then perform the same exercise 5 times with your left leg. And 1 and 2 and 3. Exercise number 2. Beginning with your right leg, point your toes toward the bottom of the bed. With the same leg, point your toes up toward your face. Repeat this exercise several times with your right leg, then perform the same exercise with your left leg. And 1 and 2 and 3. Exercise 3. Beginning with your right leg, make circles with your ankles, first to the left, then to the right. Repeat this exercise several times with your right leg, then perform the same exercise with your left leg. And exercise number 4, beginning with your right leg, bend your knee and push the ball of your foot into the bed or floor until you feel your calf and thigh muscles contracting. Repeat this exercise several times with your right leg, then perform this same exercise with your left leg. Okay, 16.3 shows a patient using an incentive spirometer. Okay, coughing and splinting may be performed along with deep breathing every 1 to 2 hours after surgery. The purposes of coughing are to expel secretions, keep the lungs clear, allow full aeration, and prevent pneumonia and atelectasis. Coughing may be uncomfortable for there's a bug on me. Coughing may be uncomfortable for the patient, but when performed correctly, it should not harm the incision. Splinting, i.e. holding the incision area, provides support, promotes a feeling of security, and reduces pain during coughing. The proper technique for splinting the incision site and coughing is described in chart 16.5. A folded blanket or pillow is helpful to use as a splint. Cardiac patients may receive their own heart-shaped pillow for splint use. Ew. The use of routine coughing exercises after surgery is controversial. Some surgeons believe coughing may harm the surgical wound and that it would be better to use other safer measures for lung hygiene, such as deep breathing and incentive spirometer exercises. When routine coughing exercises should be avoided for a specific patient, such as after a hernia repair or craniotomy, the surgeon usually writes a do not cough prescription. Procedures and exercises to prevent cardiovascular complications. Venous stasis and deep vein thrombosis, DVT, are potential but avoidable complications of surgery. These problems can lead to a pulmonary embolus, a PE, if the blood clot breaks off and travels to the lungs. Patients at greater risk for DVT are obese, are older than 40 years old, have cancer, have decreased mobility or are immobile, have a spinal cord injury, have a history of DVT, PE, and varicose veins or edema, are taking oral contraceptives, they smoke, have decreased cardiac output, have hip fracture or total hip or total knee surgery. Always assess for DVT before surgery. Sudden swelling in one leg is a common physical finding of DVT. A patient may feel a dull ache in the calf area that becomes worse with ambulation. A careful assessment and timely intervention may prevent the fatal complication of pulmonary embolism. Devices may be used during and after surgery, along with leg exercises, and are an early ambulation to promote venous return. Specific interventions depend on the patient's risk factors. Anti-embolism stockings, TED hose, or job stockings, and elastic ACE wraps provide graduated compression of the legs, starting at the end of the foot and ankle. Measure the patient's leg length and circumference before ordering the stocking size. Elastic wraps are used when the legs are too large or too small for the stockings. Assist the patient in applying the devices and ensure that they are neither too loose, or they'll be ineffective, nor too tight, they'll inhibit blood flow. The devices need to be worn properly and should be removed 1 to 3 times per day for 30 minutes for skin care and inspection. Pneumatic compression devices enhance venous blood flow by providing intermittent periods of compression on the legs. Measure the patient's legs and order the correct size. Place the boots on the patient's legs and then set and check the compression pressures, usually 35 to 55 mmHg. Figure 16.4 shows various types of sequential devices. Anti-embolism stockings may be worn in addition to the boots and may reduce some of the uncomfortable sensations of the boots, e.g. itching, sweating, heat. Leg exercises also promote venous return. Teach the leg exercises outlined in chart 16.6 and then urge the patient to practice these exercises before surgery. The exercises are important even when other devices are used. Mobility. Soon after surgery, early ambulation has many cardiovascular and other benefits. It stimulates intestinal motility, enhances lung expansion, mobilizes secretions, promotes Venous return prevents joint rigidity and relieves pressure. For most types of surgery, teach the patient to turn at least every 2 hours after surgery while confined to bed. Teach patients how to use the bedside rails safely for turning and how to protect the surgical wound. Splinting when turning. Assure patients that assistance and pain drugs will be given as needed to reduce any anxiety and pain they may have with this activity. For certain surgical procedures, such as some brain, spinal, or orthopedic procedures, the surgeon may prescribe turning restrictions. Ask the surgeon about other interventions to prevent complications of immobility in patients with turning restrictions. Inform the patient of anticipated turning restrictions during teaching before surgery. Most patients are allowed and encouraged to get out of bed the day of or the day after surgery. Assist the patient into a chair or with ambulation after the surgery, the next day, or when the surgeon specifies. If a patient must remain in bed, help him or her turn, deep breathe, and perform leg exercises at least every 2 hours to prevent complications from immobility. Anxiety. NOC planning expected outcomes. Before surgery, the patient is expected to have manageable anxiety as indicated by consistently demonstrating these behaviors: expressing a reduced level of anxiety, showing an absence of body language indicators of anxiety, e.g. hand wringing, facial tension, restlessness, dilated pupils, sweating, elevated blood pressure, elevated pulse rate. Interventions. Anxiety often causes restlessness and sleeplessness. The patient may perceive the surgical experience as a threat to life and function. Assess the patient's level of anxiety, as discussed on page 248 in the psychosocial assessment section. Interventions such as teaching and communicating with the patient before surgery, enabling the patient to use previously successful coping mechanisms, and giving anti-anxiety drugs help reduce the anxiety. Incorporate available support systems into the plan of care. Preoperative teaching involves first assessing the patient's knowledge about the surgical experience, see page 252 in the deficient knowledge section, and then providing factual information to promote the patient's understanding. Allow ample time for questions, respond to the questions accurately, and refer unanswered questions to the proper person. During the discussion, continually assess the patient's responses and anxiety level. Be careful not to provide information that might increase anxiety. Patients have ranked psychosocial support as the most important part of preoperative teaching. The informed, educated patient is better able to anticipate events and maintain self-control and is thus less anxious. Encouraging communication by having the patient state feelings, fears, and concerns can help reduce anxiety. Use an honest and open approach so that the patient can express feelings freely without fear of ridicule or judgment. Keep the patient informed by clarifying information, answering questions, and allaying fears about the surgery. Promoting rest is helpful because the stress and anxiety of impending surgery often interfere with the patient's ability to sleep and rest the night before surgery. The period before surgery is physically and emotionally stressful. To help the patient relax, determine what the patient usually does to relax and fall asleep. If the patient is able, urge him or her to continue these methods of relaxation. A back rub is relaxing and can be performed by a nurse or family member. The surgeon may prescribe a sedative or hypnotic drug to help the patient be well rested for surgery. Distraction may be used as an intervention for anxiety, especially in the 24 hours immediately before surgery. Listening to music may decrease anxiety, as well as may watching TV, reading, or visiting with family members. Teaching family members helps reduce anxiety by increasing the likelihood of support and involvement in the patient's care. Assess the readiness and desire of the family to take an active part in the patient's care. A positive sign of family interest is that of members asking questions about the surgical experience. After family readiness is determined, keep family members informed and encourage their involvement in all aspects of education. Emphasize but emphasize the important role of the family before surgery, but guide discussions and practice sessions so that family members do not dominate the session. Family members can encourage and help the patient practice exercises to be performed after surgery. Inform the family of the time for surgery, if known, and of any scheduled changes. If the patient is an outpatient, provide clear directions to the patient and family regarding any specific night before procedures, what time and where to report, and what to bring with them. Encourage the family to stay with the patient before surgery for support. Most families are anxious about surgery planned for their loved one. To reduce their anxiety, explain the routines expected before, during, and after surgery. Tell the family that after the patient leaves the hospital room or admission area, there is usually a 30 to 60-minute preparation period in the operating area, holding room, or treatment area before the surgery actually begins. After surgery, the patient is taken to the post-anesthesia care unit, the PACU, for 1 to 2 hours before returning to the hospital room or discharge area. Tell the family about the best place to wait for the patient or surgeon according to the facility's policy and the physician's preference. Many hospitals and surgical centers have surgical waiting areas so that families can wait in comfortable surroundings and be easily located when the procedure is completed. Decision-making challenge. Legal ethical. The patient is a 92-year-old woman scheduled to have a repair of a rectal prolapse. She had a myocardial infarction 4 years ago and has been medically managed for heart failure ever since. Her surgeon and anesthesiologist consider her a poor surgical risk and have tried to talk her out of the surgery, as has her family. She steadfastly insists she wants the surgery, stating, "I'd rather be dead than live with this problem any longer." She has already signed the consent for the surgery. Rectal prolapse. How will you determine whether this patient understands the planned surgical procedures and its risks? 2. Given her age, should consent also be obtained from the family? Why or why not? 3. What ethical conviction is most endangered for this patient in this situation? 4. How can you best act as an advocate for this patient? Oh, no answers. Okay, well, think about it. Preoperative chart review. Review the patient's chart to ensure that all documentation, preoperative procedures, and orders are completed. Check the surgical informed consent form and, if indicated, any other special consent forms to see that they are signed and dated and that they contain the witness's signatures. Confirm that the scheduled procedure, including the identification of left versus right when necessary, is what is listed on the consent form. Even though it might be obvious, have the patient mark the correct area for surgery. If the patient cannot reach the area, coordinate with the surgeon to mark the area before the patient is transferred to the OR. Document allergies according to facility policy. Accurate measuring and recording of height and weight are important for proper dosage of the anesthetic agents. Ensure that the results of all laboratory, radiographic, and diagnostic tests are on the chart. Document any abnormal results and report them to the surgeon and the anesthesia provider. If the patient is an autologous blood donor or has had directed blood donation made, those special slips must be included in the chart. Record a current set of vital signs within 1 to 2 hours of the scheduled surgery time, and document any significant physical or psychosocial observations. Report special needs, concerns, and instructions, advance directives, to the surgical team. For example, advise the surgical team if the patient is a member of Jehovah's Witnesses and does not accept blood products, or if the patient is hard of hearing and does not have his or her hearing aid. This information assists the surgical team in providing continuity of care while the patient is in the surgical area. Preoperative patient preparation. Facilities usually require the patient to remove most clothing and wear a hospital gown into the OR. However, underwear may be worn in above-the-waist surgery and socks may be worn except in foot or leg surgery. If prescribed by the surgeon, apply anti-embolism stockings or pneumatic compression devices before surgery. In some ambulatory settings, such as for cataract surgery, no or minimal clothes are removed. Patients are advised to leave all valuables at home. If he or she has valuables, including jewelry, money, or clothes, they are given to a family member or locked in a safe place, according to the facility's policy. If rings cannot be removed, tape them in place. Depending on the type and location of surgery, pierced jewelry may need to be removed. Religious emblems may be pinned or fastened securely to the patient's gown. Some facilities have paper emblems from a religious leader. The patient wears an identification band that clearly gives the first and last name, hospital number, physician, and birth date. An additional bracelet, usually red, identifies any allergies. A bracelet indicating that a blood sample for type and screen has been drawn may be worn, depending on the facility's policy. If dentures are to be removed, including partial dental plates, place them in a labeled denture cup. Denture removal is a safety measure to prevent aspiration and obstruction of the airway. If a patient has any capped teeth, document this finding on the checklist. All prosthetic devices, such as artificial eyes and limbs, are removed and given to a family member or safely stored, as are contact lenses, glasses, wigs, and toupees. Check and remove hairpins and clips, which can conduct electrical current used during surgery and cause scalp burns. Some facilities allow hearing aids in the surgical suite to help communication before and after surgery. If the patient is sent to surgery with a hearing aid, communicate this to the surgical nurse to prevent accidental loss of or damage to the device. Some facilities allow dentures, wigs, and glasses to be worn into the operating suite to prevent embarrassment to the patient. These items are removed when absolutely necessary. The removal of fingernail polish or artificial nails is controversial. Polish and artificial nails have been thought to affect the accuracy of pulse oximetry readings. Recent studies have indicated that pulse oximetry readings taken on fingers is affected by brown or bluish polish, but not by red or lighter color polish. In addition, pulse oximetry does not have to be measured on fingers only. Some facilities still require that at least one artificial nail must be removed to monitor oxygen saturation by pulse oximetry. After the patient is prepared for surgery and the operating suite is ready to receive him or her, ask him or her to empty the bladder. This action prevents incontinence or over-distension and is a starting point for intake and output measurement. A full bladder may hinder access to the surgical site. Answer questions, offer reassurance as needed, and give prescribed drugs. Preoperative drugs. Preoperative drugs may be prescribed regardless of the type of planned anesthesia. Various drugs reduce anxiety, promote relaxation, reduce nasal and oral secretions, prevent laryngospasm, reduce vagal-induced bradycardia, inhibit gastric secretions, and decrease the amount of anesthetic needed for the induction and maintenance of anesthesia. Drug selection is based on the patient's age, physical and psychological condition, medical history, and height and weight. Other drugs the patient takes routinely, test results, and the type and extent of the planned surgical procedure. If more than one response is required, combination therapy may be prescribed. Drug types for preoperative preparation may include sedatives like hydroxyzine or Atarax, Vistaril, hypnotics like lorazepam, Ativan, anxiolytics, e.g. midazolam or Versed, opioid analgesics like morphine, hydromorphone, meperidine, and an anticholinergic agent like atropine. Other specific purpose drugs also may be added. For example, if rapid emptying of the stomach is needed, metoclopramide or Reglan may be prescribed. When procedures are long or stress ulcers are likely, an H2 histamine blocker, e.g. Tagamet, or ranitidine or Zantac is used. Preoperative drugs may be given when the patient is on call to the surgical suite. After positively identifying the patient using the arm band and asking the patient to state his or her name and making sure the operative permit is signed, give the correct drugs in the correct doses. Then raise the side rails. Place the call light within easy reach of the patient and remind him or her not to try to get out of bed. Place the bed in a low position. Tell the patient that he or she may become drowsy and have a dry mouth as a result of the drugs. A more common practice is for the preoperative drugs to be given after the patient is transferred to the operating area. This practice permits the surgical team and anesthesia personnel to make more accurate assessments and have last-minute discussions with the patient not yet affected by drugs. In addition, after the patient is in the preoperative area, drugs can be given by the IV route. Monitoring equipment such as continuous pulse oximetry and ECG are more readily available in this area. The oral or IM route is used less often because of variable absorption rates. The surgeon may prescribe a prophylactic antibiotic to be given right before or during surgery to reduce the risk of surgical site infection. The antibiotic is usually given within 60 minutes before the incision is made. Patient transfer to the surgical site. In the immediate preoperative period, review and update the patient's chart, reinforce teaching, ensure that the patient is correctly dressed for surgery, and give prescribed preoperative drugs. Use a preoperative checklist for a smooth, efficient transfer to the surgical site, figure 16.5. The patient, along with the signed consent form, the completed preoperative checklist, the chart, and the patient identification card is transported to the surgical suite. Most patients in the hospital setting are transferred to the surgical suite on a stretcher with the side rails up. In special circumstances, e.g. patients requiring traction, those having orthopedic surgery, those who should be moved as little as possible, the patient is transferred in the hospital bed. Other factors that influence the decision to transfer in a bed are the patient's age, size, and physical condition. In ambulatory settings, patients either walk or are transferred to the surgical suite on a stretcher or in a wheelchair. Decision-making challenge. Legal ethical. You are about to send the patient, described earlier in the decision-making challenge, on page 260, to the surgical suite. After her competency was established, she signed her consent form but refused to sign a do not resuscitate order. As you are giving her the prescribed preoperative drugs, she asks you just what the DNR means and says she did not sign it because she was afraid that if she was choking, no one would do anything to help her. How would you explain a DNR order to this patient? Should you have her sign such a document at this time? Why or why not? What risk factors does this patient have for specific intraoperative or postoperative complications, and why? Okay. Evaluation outcomes. Evaluate the care of the preoperative patient on the basis of the identified nursing diagnosis. The expected outcomes include that the patient states understanding of the informed consent and preoperative procedures, demonstrates postoperative exercises and techniques for prevention of complications, has reduced anxiety. Specific indicators for these outcomes are listed for each nursing diagnosis in the planning and implementation section. See earlier. All right. Get ready for NCLEX examination. Review these key points for each NCLEX examination client needs category. Safe and effective care environment. Ask the patient if an advance directive has been completed. Ask the patient to explain in his or her own words what surgical procedure is being done and why. If the patient's explanation of the scheduled surgery is not consistent with the documentation, notify the surgeon and request that he or she speak to the patient. Use appropriate identifiers, e.g. hospital number, the identification band, asking the patient to state his or her name to identify the patient. Do not use room number or bed number to identify the patient. Ensure that the patient is wearing proper identification. Okay, 16.5 has a preoperative checklist example. Ensure the patient is not asked to sign an operative permit or any other legal document after the preoperative drugs have been given. After the patient has received preoperative drugs, keep the side rails up and the bed in the low position. Communicate to the surgeon and anesthesia personnel any physical or laboratory changes that may alter the patient's response to drugs, anesthesia, or surgery. Health promotion and maintenance. Teach patients about dietary restrictions and preoperative preparations. Teach the patient specific interventions to perform after surgery to prevent complications, incision splinting, deep breathing exercises, and range of motion exercises as described in charts 16.5 and 16.6. Psychosocial integrity. Pace your interview to match the learning needs and style of the individual patient. Encourage the patient to express his or her feelings regarding the surgical procedure or its possible outcome. Explain and provide written information for all diagnostic procedures, restrictions, and follow-up care to the patient and his or her family. Communicate any concerns or fears the patient has to the surgeon and anesthesia personnel. Physiological integrity. Check that documentation for any procedure to be performed on one of a paired organ or extremity clearly indicates which organ or extremity is involved. Okay. If required, ensure that dentures and any other personnel items are removed from the patient before the patient is transferred to the surgical suite. Selected bibliography. No. Okay, that was chapter 16, Care of Preoperative Patients.